Okay, let's go ahead and get started since the top of the hour has hit. Good day or good evening, everyone, wherever you may be joining us today for another session of Virtual Global Spine Conference. We'd like to welcome you again, both to our loyal participants and certainly the new ones as well. We are excited today to have one of our very own panelists, Dr. Alex Mameghani, who many of you certainly know. And if you don't, you should get to know him and his work, as he is certainly one of the more avid teachers and educators, shows terrific cases, and really navigates through some very interesting discussions online. And we are absolutely thrilled to have him with us today. And he will be going over some challenging spine cases that hopefully we will know the answer to, and he won't stumble us too much. But Alex, welcome, and thank you for showing cases today.
Yeah, hello, Ali. Hello, everybody. This is me from Switzerland, and I really appreciate that you all joined in. It's midnight here in Switzerland, and it's a beautiful fall, but it's a flu season or a COVID season. Another wave is coming here in Europe, and maybe I'm a little bit ill too. Last week was a bad week for me, but nevertheless, I want to show you some challenging cases. First of all, I want to show my I have to proceed with sorry, now it's so my disclosures. I will show some one special implant from their presenters, but all these disclosures I have are not really related to the cases. But I'm an AO Spine member for a long time now, and this is very important to mention because I'm really heavily influenced by this organization and the founders of this organization. So my first case is very easy, but it was a challenge because of the indication. So she was 70-year-old. She was a lady with a severe pain. As you can imagine, this herniated disc L4-5 made her life really a nightmare. And this is the X-ray. And she was a patient here in our hospital, very well known in oncology. And she was unable to leave hospital because of this pain, because of a herniated disc. And this was really the difficulty in this case, because what do you do when a patient has a disease like a herniated disc? You treat her with opioids or NSAIDs, and you do some epidural injections, or even you can go and choose surgery. But she hadn't had really a severe neurological deficit. She was just in pain. So why is this a challenging case? Maybe you can see it on the X-ray. You can see this catheter in the ureter on the right side, and there's a stand. And the stand is due to her pancreatic cancer. As you know, pancreatic cancer is really a severe burden. It's when it's not, when you can't operate it, if you can't do an en-bloc resection as a Whipple surgery, the patients will die, and they will die within several months. This is not a cancer you are living with 5 years or 10 years. And so this was a difficulty. We sent her to the anesthesia to quantify the risk, and she was ASA 4, and she had all these diseases you don't want to have, lung, COPD, the heart was not so good, but it was good again. Of course, she was on a NOAC, she was on rivaroxaban, as everybody today gets some blood thinner. And so this was this simple herniated disc and a patient in pain. And I just want to ask you, what do you do with her? Just some math, 6-month life expectancy would be 180 days. When she is 2 weeks in hospital, she spent approximately 8% of the remaining life she had in hospital. If you have a life expectancy of 3 months, then she spent a third of her life expectancy in hospital when she stays for 4 weeks or in a rehab. And she has something else to do. She has to organize something. She doesn't want to travel, everything like that, but she wants to organize. She wants to say farewell to her loved ones. And so what do you do, Ali, when I ask you A, B, C, D? I can't see the chat box right at the moment, but what do you do in this situation when you know the patient will die in several months? You posted a nice tweet yesterday. This was about cord compression, and this is not a cord compression. This is just a herniated disc. But I would be curious, what would you do in this situation? And she is definitely convinced that she would say yes to every procedure that takes away her pain.
Yeah, thanks, Alex. I also put in the chat box the question as to see what some of our participants and the audience would do. Yeah, you're right. This is not straightforward. I think, you know, at the end of the day, we think about this every day, which is, can we help the patient or not? How can we help them? And especially in patients with active oncology or active cancer, we want to make sure we don't delay or don't interfere with any systemic therapy or systemic treatment or quality of life issues. So this one is a little hard. Boy, I would have to say that I typically, if there was no oncology history, if there was a different scenario, I tend to not like to operate on these patients as an inpatient. I like them to cool down, cool off, you know, see me again in clinic, unless they have caught equina. In this particular case, I don't know if I would be a big fan of more injections. She's immunocompromised, raises the chance of an infection. You know, again, for the majority of patients, I wouldn't do this as an inpatient, but if she was really in severe pain and had a really, really severe radiculopathy, I probably would offer a discectomy in the hospital. It's one of the probably rare cases where I would do that. And of course, my good colleagues there, Dr. Selby and Dr. Baisa, are right away contradicting me, and they're saying no more epidural injections. So maybe I'm probably going to be a little bit more aggressive with this one.
Yeah, so is there a consensus in the chat box? Is there some else procedure, some else other commands, or so I will just say, because it was the challenge from indication from my talk today, and I offered her a surgery, and surgery was fine. I think the talk about indication and risk, everything, took longer than the surgeries as well, because it was like 60 or 65 minutes, and she was really happy. And of course, she died several months later. So I cannot say, I think this is some kind of our job in palliative medicine, in palliative surgery, and you will not really make a patient so happy, because she is so interested in other things that as soon as she has forgotten the pain, she's not so thankful like all the other patients we are having, who suffer for years. And she was really, she was glad and she was thankful, but I've never seen her again. And I would do it again too, because I think it is an important part of our job. So this is your tweet, Ali, and I loved it because I think there are so many things, and you reduced it to these 4 things. Let's proceed to the next patient, because this patient is 60-year-old. He's male. He's got pain in the night. He has got an attacked gait disorder. He has a weight loss. And I don't know whether Wendy is here or not, who can give up some hints from the radiologic part point of view what this cancer might be. You can see the majority of this metastasis is from posterior. It's a dorsally compression of the spinal cord. There's another metastasis in the vertebral body, some levels below. And this is a CAT scan. You see it's a destructive tumor. It's quite solid. It's very good perfused. This is a contrast CAT scan. And you can see some prevertebral contrast as well. I think nobody can make a guess what kind of cancer this is. This is an actual CAT scan, and I think you should all be aware of this tumor mass in the axilla on the right side as well. And you can see this is a huge mass, and this is not the only mass. The patient has gone to multiple metastases and lymph nodes everywhere, and he's got several bony metastases as well. He's 60 years old, and when we come to your tweet, it's an esophageal mucinous adenocarcinoma. It's really a nasty tumor. And I would love to hear from you, Ali, again, because you tweeted this yesterday. What would you do with this tumor? Would you go for laminectomy? This is your T2 sac, mid-sac view. Would you do a laminectomy? Would you do a laminectomy plus stabilization, or would you do a non-surgical treatment? You can ask me every question you have, because you're only interested in 4 things, don't you?
Yeah, Alex. I'll also, again, ask the participants again what they would do. And while some of those answers come up, you know, thanks for mentioning my tweet. Really, as you know very well, a lot of us, including me, you know, when we tweet things like that, or when we write things like that online, it's usually inspired by a true story, right? It's usually inspired by a clinical scenario of somebody we saw in clinic or in the hospital. And you know, we do spine tumors, right? We do a lot of spine tumors as neurosurgeons, and certainly as orthopedic spine surgeons. And you know, we're very familiar with Takahashi, the Nome scale, the SIN score, and all of those kind of fancy classifications that are part of our, you know, it's part of our literature. It's part of what we do. But you know, really the reason I said what I said, which is, boy, you know, a lot of times I think about it and I overthink it, and you know, you go through all of that. But more and more, I'm coming to terms with the fact that there's really only 3 or 4 things that are important in the decision making. You know, yes, if it's cervical thoracic junction or transitional or all of that, and if the score is 10 or 13, I get that. But boy, at the end of the day, you know, at least for me, how old is the patient? What's the tumor burden? Is it a bad cancer or one that they can live with for a long time? And what do they look like, right? There's a picture is worth, in this case, in oncology, 1,000,000 words. When you see the patient, you kind of get a gut feeling of how they're going to do. Sometimes we guess wrong, but I think when you do this long enough, you kind of have that sixth sense about patients with oncology. And you know, really nothing against our colleagues in radiation oncology or medical oncology, but they are almost always unlikely to give you a life expectancy or prognosis. They're just not. You're the surgeon. It's going to be your decision to operate or not. Part of a multidisciplinary team, I get it. But usually when it's an urgent consult or middle of the night, it's you have to make the call. So that's just a quick background about why I tweeted that. It was based on a clinical scenario that I had recently. But yeah, sorry about that long answer, at least that long.
But I love it. I love it. I love to hear it. I love to hear this long answer, because is there an order in your 4 things? You mentioned first histology. I think I will show another slide. it is so difficult for me as a spine surgeon to know all these cancer entities, because lymphomas, how many lymphomas are out there? How many colorectal stagings are possible? I can't be an expert, but you see, in these tumor boards, we're discussing and we hear and listen to all these experts treating this cancer quite better than me. But I think the most important is your gut feeling. You mentioned it. It is just look at the patient, see how he moves, see how he behaves, and then you see in your mind all these complications they can run in. And I now check the chat box, and many said just the debulking, which means it's the least invasive surgery, no big plays with screws. But this patient, he's 60 years old. It's not old. Do you have an age threshold? Because you mentioned, secondly, the patient age.
Yeah. So my answer to that is this, and yeah, I do also see, doctors Daniel, Selby, Baisa, most everybody's going for A, maybe some stabilization. So I don't have an age cutoff, but yes, of course, it makes a big difference, right? A 90-year-old who comes in with spine metastasis, you're just going to look at them a little bit differently than a 40-year-old that comes in with spine metastasis. It just is, and now, yes, that 40-year-old patient with metastatic pancreatic cancer potentially could live only for 2 or 3 months, yet the 90-year-old with myeloma or breast cancer can live a lot longer. I know that, I get that. But yes, I don't have a cutoff, but certainly, my mantra is the older the patient, the more tumor burden they have, the less likely I'm going to be aggressive. The younger the patient, the less tumor burden, the more focal the disease, the more aggressive I'm going to have. If there's just, I don't have a cutoff.
Yeah, and this is my solution. We voted against surgery, and I tell you why. Because when you go to esophagus cancer, the patient are dying rapidly because of their malnutrition. You are running behind them with the parenteral nutrition, and you see when there is no metastasis, when it's stadium M0, the malnutrition is like 40.3% of patient. When there is one metastasis, and our patient has not one metastasis, he has got like 1,000 metastases, the malnutrition rate really explodes in nearly any cancer. And this is really important for me. I can't memorize all these bars, but you see the breast cancer on the right side, where malnutrition is not really a big issue, and you see the pancreas and the esophageal cancer. And I didn't know that esophageal cancer is worse than pancreatic cancer. I thought pancreatic was the worst, but esophagus is really a beast and we voted against surgery. And this was challenging as well, a case for me, because it's really difficult to let a patient go into a severe neurologic deficit, and you watching there and you can't do anything. So
yeah, I was going to ask you, I'm sorry, Alex, sorry to interrupt. I was going to ask you about that last case. I think the presentation was gait instability, Okay, so let's say this patient came in, the same exact scenario, 60-year-old patient comes in with back pain, not just ataxia, but let's say they're coming in with acute paraparesis. Yesterday they were walking, today they're 2 out of 5 motor strength in the legs. Does that, knowing everything that you just said, does that change your decision or not really, because the disease burden and how, basically how malignant this lesion is?
Then it's an emergency talk with the patient. You have to make a decision within several hours. And then I usually recommend A. solution A, like debulking laminectomy. It is different. This is what you mentioned with the systemic tumor burden, the functional status. And this is why I agree with your tweet so very much, because it's really different whether it's an ataxia or whether it's a paraparesis and the loss of control of defecation and urinary system, and it makes a difference. And so in this situation, we have time, and we can discuss in an acute setting, acute paraplegia. I usually vote for A. I am really more aggressive because the patients have got one opportunity to go into surgery or to stay paraplegic for the rest of their life, remaining life. And so I would go for an A as well. So my third case is also like and 50, beginning 60, 57-year-old male patient. He has got progredient neck pain on the right side, and you can see the images. On the left is the left side of the patient. Then we go via the middle to the right side. And I don't know whether many have seen this tumor and think about a tumor entity. What could this be? Just write down in the chat box. I proceed to the next slides. This is the actual, you see C3 is half destroyed by this tumor, while C4 is pretty intact. Yeah, so again, here, the sagittal a CAT scan, C4 is intact, C2 is intact as well, a little bit eroded in the basis, but it's mainly a tumor in C3. And because it's a tumor in C3, we find the situation challenging. Because what is your strategy? The patient has no neurological deficit. He's just neck pain, and he is able to walk. He can move his arms, and this situation is like month. He has got weeks and month. He has got this pain. So we have time again, and we can have a perfect plan. You can notice here the vertebral artery on the right side goes straight through this mass, and this is the actual post contrast. You can find the vertebral artery with a nice flow void, and we did several examinations as well, and the vertebral artery is nicely perfused, and there's no problem. And what is this? What could this be? And this is a renal cell carcinoma in C3. And because of this tumor, I'll just ask, because you cannot give one solution. I would love to hear from you. I think embolization is quite clear. Everybody today would love to have an embolization of this tumor, whether he goes into surgery or whether he's not going into surgery, because embolization can probably stop progression. Would you do radiation therapy preoperative or like a neoadjuvant? Would you put the patient under immunochemotherapy in combination with radiation, or would you go for a surgery like a short posterior or a long posterior? Would you do a corpectomy C3? Would you do a radical debulking? The patient is not clear how many metastases he has. Maybe it is his second metastasis. So you can also vote for a non-block resection, sacrification of the vertebral artery. I would love to hear anybody who goes through this checklist and say yes or no. Otherwise, I would proceed. It's a little bit difficult from this presentation to have a perfect plan. But maybe again, Ali, when you're there, can you share your thoughts?
Yeah, these are great, really good cases, because I think there's probably more than one good or right answer. We'll also see what our colleagues on the call think. I think you're right. You just go one by one. I'll tell you what I wouldn't do, right? Let's cross off the ones that I think
Yeah.
hopefully most of us would not do, right? So, sacrifice the vertebral artery, en bloc resection for metastatic renal in this area. I probably wouldn't go for those. And then, embolization, if you're thinking about surgery 100%, I try to embolize all of those, of course. And then really what's going to happen after those three options, this is where a nice discussion with tumor board and your medical oncologist and radiation oncologist to come up with a plan. But for me, this is going to be either, since he's intact, either chemotherapy and close follow-up for instability, or embolization, probably in this case, posterior separation surgery, nice wide resection, and maybe C2 or C1 to C5, or C4 or 5 stabilization. So either short segment decompression stabilization versus immunochemotherapy with close follow-up. Because right now, obviously the systemic therapy is excellent for renal. So I don't think you can go wrong with any of those. This is exactly why tumor boards are helpful in this case.
Yeah. Can you remember the time when you did a tumor? Maybe you didn't know that it's a renal cell carcinoma because biopsy was not clear. You went into surgery without embolization?
Yeah, I mean, renal bleeds with or without embolization. I'm not gonna lie to you. I mean, this it's tough, and I think the vast majority of times we knew because we got a CT guided biopsy. So this is somebody that I think that's what you did. You get a biopsy, you've got to know what it is going in, and if they're neurologically intact, I have no problem starting first with systemic therapy and radiation, and then pulling the trigger on surgery only if they develop deficits or instability. Yeah, I mean, they're going to bleed with or without embolization.
Yeah. And do you think that you can achieve a fusion in this tumor mass and this tumor destruction? Do you think that you can control it, or is it just a stabilization, like an internal bracing in this really destructive process?
Yeah, that's a good question about fusion, and I think it is important to note. I think what you're trying to allude to, that at least in metastatic spine surgical treatment, the goal is immediate fixation, not necessarily long-term fusion. We'd love to have long-term fusion, but really the primary goal is immediate fixation. I don't know if we achieve a lot of much fusion here. Unfortunately, many of these patients don't have more than 2-year follow-up. But certainly I would probably, in the posterior elements there, if it's focal to C3, you may be able to get lucky and get a fusion mass between C2 and C4, but I wouldn't count on that. Yeah.
So it's really, all my thoughts are included in your answer. It's really nice that even when an Atlantic Ocean separates us, the treatment could be pretty similar. So this was my solution. I went first after embolization, of course. I went to the back and I stabilized from the back and did a tumor resection. Let's not say tumor resection or debulking. Let's say I did decompression of the spinal canal from the lamina on the right side, and then we turned the patient. I went from anteriorly, and this is the post-op image after I think it was 1 week, and the patient was fine. No, it was 4 weeks later. You see the prevertebral swelling is less, and this is a closer look. You can see some clip material. You can see some embolization material on the right side, and you see there's no fusion present here. And now we can make a time warp. This is 3 years later. The patient is still very fine. He is very happy. 3 years in renal cancer patients is not surprisingly long today. So we have like 5 years. I've even operated on a patient with a recurrent metastasis and the same lesion like 5 years later. So it was a nice rendezvous. The patient was unlucky, of course, because he had a recurrent metastasis, but she was really confident that she can again undergo surgery. It's 3 years later, you can see some fusion mass in the CAT scan. 3 years later, it's really healed. The posterior elements, I was a little bit afraid of my muscle lateralis screws. The isthmus screws were very short in C2 because of the vertebral artery. I couldn't place any longer ones, and I couldn't go into a I didn't want to go into pedicle screws because of the tumor in C3. But it was really a good result and a good outcome. And surprisingly, the bony mass on the right side came back a little bit. You can see exactly where I did the laminectomy, but on the right side, surrounding the vertebral artery, again there is some bone, and I didn't do a debulking over there because it was too dangerous and it was not necessary. And so it was really nice to see this power of radiation, the power of immunochemotherapy in renal cancer patients, plus the surgery. And he was really happy for a long time. This is a coronal view, and this is the PET scan. You can see all these mediastinal metastases in the lung, the kidney where the primary tumor is, but the C-spine is like tumor-free. So the radiation, the chemotherapy, and the surgery were quite effective, and there was a local control, a local tumor control, and the patient was really happy that he was able to go back to life. So there was a challenge because of the localization. The next case.
Sorry, Al, just before you're very modest and humble about this. You're moving on. This is a great result. I mean, technically, it's a very nice construct. To be able to go and do that high cervical corpectomy and not get into major swallowing issues with all of that tumor that's invading the soft tissue. That's a really nice result. I mean, if we can pull that off every time with a front and back on a renal, that's great. So congratulations. That's a really nice result.
Yeah, but the patient is not among us any longer. That is really the hard one. Sometimes the letter comes into your office when the wife mentioned that he passed away, and full of thanks. And it's really, these are some highlights in your career, and you will always remember these. So this is another patient, the same age, probably a little bit younger, like me, and he has got a renal cell carcinoma as well. You can easily see the primary tumor on the right kidney, and there's destruction of the posterolateral aspects on the left side, the invasion into the vertebral bodies, and the patient was really unable to get up because of a radicular pain somewhere arising from the thoracolumbar junction, and it was really hard for him to get up, and he was looking for help, and the oncologist called us and they asked us, what can we do? So again, embolization, and you can see all these highly vascularized tumors, and these tumor they bleed with and without embolization. This is so important to know, and this was my solution. I chose open surgery. I wanted to fuse the spine, and this is my. I think this will be my last renal cancer patient I did open. It was fine from the result. The patient was happy. This is 1 year later. You see the fusion mass on the right side is present. It's a solid fusion. But the tumor burden with the other metastases was proceeding, and the patient was in hospital for like 3 weeks initially after the surgery. He was struggling with anemia because he lost like 2.5 liters of blood, and so it was very invasive. And although the primary outcome was good and there was no complaints, I would do something different. I would go for MIS stabilization without open debulking, maybe without embolization as well, and start with the radiotherapy plus modern chemotherapy for local tumor control. And I guess we would have achieved the same outcome, because the local tumor is not the limiting disease, the limiting factor of the whole disease. And I think today smart MIS solutions work very fine, and I can recommend everybody to consider first an MIS situation in these tumor entities. This is a little bit different to the paradigm like 15 years ago when I started with the tumor surgery, because then it was always tumor surgery is open, it's not MIS, it's not microscopic, it's always open to control bleeding and to control everything. And I would love to hear from anybody who would use MIS solution as well, because I think we can do a little bit better than I did in this case with an open surgery.
Yeah, Alex, we're also open the chat box here to see if anybody has any comments. But yeah, I think you basically really hit all the right notes in this. You know, we talk about this a lot in terms of MIS for deformity, MIS for degen, you know, tubes versus a retractor for a discectomy, which, you know, when you look at this, it kind of sounds silly, but because really what you said, I think, is very accurate and resonates with a lot of the current thinking, which is you really want to do less in these cases, get them to the adjuvant therapy quicker. And these big open incisions, sometimes you have to do them, but if you can avoid it, you know, why not? So I agree with you. I think PERC stabilization is a great option for a lot of these tumors. And if nothing else, that stabilization really helps patients with their kind of instability pain, right? So in the presence of either very mild symptoms or neurologic deficits or no neurologic deficits, PERC stabilization plus or minus an MIS LAMI is a great idea, and I think you're right. A lot of people are heading kind of heading in that direction.
Yeah.
Dr. Rao asked about thoughts on carbon fiber screws.
Yeah.
I know we talk about that a lot. We actually had a few sessions on just that topic with a couple of guests. What's your take on that, and what's the overall consensus on those in your country or in your region?
Yeah. I love the discussion, and what I don't like is that I receive more and more emails and invitations from the companies who are selling carbon screws. I think, and we have a proton beam center here, and they need metal-free cytos for their proton therapy. If you do a stereotactical, if you do a conventional radiation therapy, you don't need carbon implants to achieve a good result. I think when did we start with the radiotherapy? It's like 80 years or 70 years ago. Even in the World War II time in Germany, radiotherapy was performed while the cities were bombed. And this is an old therapy, and we know it can be really effective. this modern proton therapy is really a big step forward, but not in all these tumor entities. And for renal cell, we can use carbon screws, and we can put him in proton therapy. But this is a systemic disease. You can see the metastasis to a level up. It wasn't there at the moment when I did the surgery. It was out of the field. So your expensive carbon implants wouldn't make any difference. We achieved local tumor control with stereotactic conventional radiation therapy. So I don't choose these carbon implants, but I would do this in a chordoma or in sarcoma or any other tumor entity where proton or heavy ion therapy would be really the better option. So the next case is one of the cases I showed in the video on Twitter. Now we have a young patient with a fracture L4. He was in a car. He wasn't the driver, and he had no neurological deficits. So he was awake. He was able to move his toes, and sensory everything was fine. So we had the time to make an MRI, and we've seen this severe compression of the cauda equina without a cauda equina syndrome. And I would love to hear from Wendy, if she's there, what is about this contrast in L1 or L5? Is this any significant contrast uptake? Is there an injury or not? I ignored them. For me, it was just a L4 burst fracture. A complete burst fracture we know from the AO spine classification system, and luckily it was N0, so we have the time and we could do a surgery before neurological symptoms come up, but we don't have to go into surgery at night at midnight. So this is the coronal and the actual view. You can see the split and split burst fracture, complete burst fracture. And what's your recommendation? Please just write down from A to E in the chat box whether you would go for a conservative treatment, brace the patient because he has no neurological deficit. I hope nobody mentions A because I'm an AO spine member, and AO means always operate. Or would you do an open posterior solution? Would you do it a minimal invasive? Are you able to reduce the fracture with an MIS system? Would you do a 360 fusion in a complete burst L3-5? Or would you go 2 up, 2 down plus corpectomy? This would be a nice. I see now that C was voted, and I would love to hear some more comments on B, open or MIS solutions. I'm just waiting for the chat box.
I think Dr. Gibbs is with us. Wendy, can you hear us? Because I was interested in her opinion as well on that contrast.
Yeah, you see this shady in L1 and L5. I don't know.
My question is, why did you get a contrasted MRI?
Yeah, I asked the radiologist the same question. He said it's a standard in trauma, and I said okay. And when I want to have a contrast view, I was saying there's no need. But it is there, and I can't tell you what this is. So another miracle in the life of a spine surgeon.
I think we're getting some responses for C. You know, I think there's also an F option, which is MIS 1 up, 1 down. I know one person who'll vote for that.
Yeah. And I didn't fill in the index screws option as well because I don't like the index screw, but I think it would be the G.
There you go.
So
And he's neurologically intact. The patient's intact.
yes, he's
Okay.
really N0. He was really fine. To the surprise of the radiologist, he expected that the patient is paraplegic in a cauda equinosis, but no, he wasn't. He was fine, and so there's a bad correlation between radiology and clinical experience.
Hey, Alex, it's Wendy. Sorry I couldn't answer sooner. I'm driving, so I can't look, but I'm at a stoplight now.
Okay.
I was
Sorry,
just going to
Wendy.
ask you, show the MR again. So where is contrast standard for trauma? Where is that in your country? Is that right?
Yeah, I was surprised, and maybe I think it was really a mistake. They did an error and they did this contrast sequence, but they didn't want to admit. But yes, there's a contrast, and you can see in the steer sequence as well. This is the third from the left. There is a change as well, not in T1 and in T2. He couldn't explain.
So you're saying what are all those different things? It's just you don't know what they are because they don't have cancer or anything else. Is that right?
Yeah, no, he's young and healthy.
It has to be something vascular then, right? It just has to be the vascularity of the body somehow. Right? Isn't that the only option you have? It's not anything to do with the trauma, but the anatomy.
Yeah.
Could that be spine surgeon friends? You can tell me better than I know.
No, I can't tell you because I did what I did is I ignored it, and I ignored it through the surgery and post-op time, and the patient, I know him, he's still in some control here. He has no problems at all, but I can't answer the question what I can see here on the contrast sequence. So now finally, Professor Baeza also voted for C, an MIS solution. And Ali, you mentioned the magic word ligamentotaxis, and you wanted to remove the screws. So I just mentioned on Twitter that I was taught here spine surgery from Swiss spine surgeons. And I think this is something that is quite spread worldwide more and more. Just turn him into prone position, let ligamentotaxis do its job. It's not my job, it's ligamentotaxis that solves the problems. Throw in 4 or 8 screws and 2 rods. This is a surgery less than 120 minutes, minimal blood loss. I can do it full navigated and the outcome will be good or excellent anyway. So what is a good outcome? Of course, no neurological deficit, of course, no pain, of course, return to normal activities within a reasonable time, like let's say 9 months, 6 months, 9 months. And I think this is really something you can achieve with many solutions. I show you what is what my teachers taught me, and what is still my solution for the young and healthy patients with severe burst fractures, with severe injuries of the spine. Margal, we know him from the Margal screws and the massa lateralis technique. He published in 1985 a book, a chapter with his boss, Professor Weber, and it's written in German. So the only thing you have to do is learn German and read this book to understand how to reduce complete burst fractures. It's very easy, and German is not that hard. We don't say burst fracture, we say Berstungsfraktur. It sounds so aggressive, and so our treatment is aggressive as well. So in this book, you find really nice and well-known and often copied diagrams and schemes. These different types of injuries. You find everything about modern classification systems, because Margal did the first AO classification system, and what we are using now for terms like B or C injury, everything grew up in his mind. He was so smart. And you can see here, because he was the first surgeon who did reduction maneuvers in severe spine injuries like burst fractures. He was the first. You don't find publications from 1960 or 1950 how to reduce a spine injury best. We know there were implants like rods, and Roy Camille did some plating and screws as well. But Margal was the first.
Sorry to interrupt. Are those facet screws? What are those?
Yeah.
Oh.
Yeah, these are facet screws. You know the long.
Who put them in, the surgeon or the pain management doctor? No, just kidding. Just kidding.
Yeah.
The inside joke here in the U.S.
It is funny because the pedicle screw was the long shunt screw, which was used only for reduction and for retention of the reduction. And the translaminar facet screws, they were performed to achieve the fusion. You see the grafting material. This upper is a monosegmental fusion. The lower one is the bisegmental fusion in a complete burst fracture. The upper one is an incomplete burst fracture. Like this is A3 and A4 fracture, and this is how Margal did it. And you can see how he bended the shunt screws. They were made from steel, of course, German steel, and he managed to really change the world of spine surgery with his maneuvers. And everything is written in this book from 1985. You can see you can also apply compression as you want. You can go through the lumbar sacral region. You can do four segmental fracture reduction maneuvers. He was the genius because he didn't only say, so it has to be, he also invented the implants, everything this, but it was an external fixation system. And the next generation did the internal solutions. So beautiful images, really nice knowing where else the entry point. He always pointed them with the K-wire, checked with fluoro, and of course he was a freehander. There was no navigation. And today there is this USS fracture system I use, still I use it. It's 20 years old. It's the AO fracture system, USS fracture system. And this is how the burst fracture looked after I put him into prone position. The reduction was not complete. Of course, you can accept the situation like it is now and put in some MIS screws, and the fracture, the collapsed vertebra will heal. We have some scoli now here. The alignment in AP is not good, but with the fracture system, and it is the same principle Margal described in '85 in his book. I put in these long screws. I did some bending, a reduction. It takes some time. It's difficult, of course, but I can achieve restoration of the vertebral height. And then when you compare to the first image, maybe it's not so nicely to be seen here on the screen, but you can really achieve a good lordosis restoration of the height of the height it has to be, and correct the coronal balance as well. So, and then the second is you can decide what to do next. You mentioned you do it percutaneously and then remove the implants after 9 months or 12 months. But what is happening with this reduced fracture when the patient gets up and starts to walk? The system and this is a mono, this is not a polyaxial system, will not hold the reduction. The patient will go back into a kyphosis. The discs are injured, and we will have a loss of these reduction. And so this is why I added the anterior support. I did a 360 fusion, and this is for the young patients. He is able to get up after surgery, return to sports after 3 months, and because he's healthy and he's not a smoker, the outcome is really good. It's not better than if you do it with an MIS solution, but I think I'm really happy with this lumbar distribution index. This is the L4. You can still see the upper plate because I didn't resect the complete body. It is good. I think from the sectoral alignment is good. Another patient here, 70 years old, sports accident.
Alex,
yeah.
Sorry to interrupt. Can I just make a comment on that last slide? First of all, that obviously it's a phenomenal result, and I was worried when I didn't see a corpectomy, because if you're an orthopedic spine surgeon from Germany or Switzerland, you got to do the corpectomy. So I'm glad you did it. The second thing, which I think is really important to highlight, because I do see on the participant on the list here that we have some folks and trainees, some fellows with us. I think what I like about what your thought process is, and this is something we're trying to emphasize in different platforms, is trauma is not just two above, two below in a cage, or decompression infusion. Trauma has serious deformity implications, and especially in the lower lumbar spine, right? And especially in a young patient. So the worst thing that you can do for this poor kid is fuse him or her, I think it's a him, fuse him in kyphosis or flat back and create lifelong issues for him. So I really like how you thought about the deformity principles, and you wanted to realign him, get the lordosis. And I really encourage especially the younger folks here and the younger surgeons, to ensure that they don't look at a trauma case as just a hardware case and instrumentation. It's potentially a serious deformity case, and you did a really, really nice job realigning him. So I just wanted to emphasize that. I know you went through it. I wanted to just say it again so the youngsters amongst us here hear that.
Yeah, thank you. I think this is really important. This is one opportunity to make difference for the patient's rest of the life, because if you have a flat back in your 22 years old, you're very likely to keep this flat back for the next 60 years. Maybe you need an osteotomy the longer up. And I think now the patient lost 2 motion segments. Yes, of course. And of course, there are solutions without losing motion segments. And maybe in 10 years, we all do cement these burst fractures with the best cement on the world. I don't know, but this is a therapy described from Margal like 40 years ago, and his experience is like 50 years ago, 60 years, and it works. And just because we have now minimal invasive solutions available doesn't mean that the old ones are bad. So the next case is a bit easier because I don't show all these images. This is the burst fracture with the dislocation. So the combination makes it a C injury. Please disagree with me, but this is a C from the modern classification system. And this is a post-op after reduction. The same way, you can see the 2 discs look like healthy, and then you can make a decision whether you can fuse it or not. I talked to the patients and the patient's parents, and here I did the same just to maintain the alignment, but you don't have to. You can stop here after reduction, after restoration, and solving the big problem, decompression. The patient has had neurological deficits. or you can go and fix it. You can fix it later as you want. And the last case from the Twitter is fast as well. This is the impression. This is an A3 fracture, severely displaced the posterior fragment. And here the same, after using all these maneuvers, I managed to restore the good lordosis. It's like here, the same again. And maybe you can see on the video when I use this and I'm wiggling and twiggling, this is like chewing gum sometimes, a fractured vertebra. There's many things are possible here. And you can really try to achieve it. It's not possible to do it navigated. You have to throw in the fluoroscopic view, and you are doing all this in leads, but it's worthwhile. And I think the principle from Margal, lots of radiation in the operation room. It's a good tool in these severely TL injuries. So now it's 1 o'clock. I managed in time. I thank you very much for listening to my old techniques and aggressive and 360 surgeries. And I think you can understand why I think this the principles our teachers found out are still there. We have to obey them, and these MIS solution systems, I use them more and more, and especially in the elderly patients where the bone quality is bad, and the patients don't cope with big surgeries so good. But we know from SCOLI patients, from AIS patients, where you fix from T4 to L3, huge surgeries, much bigger than these ones. And the patients are really doing well, despite of open surgeries, blood loss, everything like this. Our patients, I've shown these three. There are young, healthy patients, luckily non-smokers, and the complication rate is really low. But you have to invest a lot more time and a lot more considerations in your surgical plan than just to put the patient prone on the table and throw in some screws percutaneously. Sometimes I do this when the surgery has to be quick, and the solution is okay. No severe lordosis, loss of lordosis is there. I do this as well. It's not a bad solution. I do this, but it is not the art of trauma surgery. And I think Margal did such a good job, and some Swiss surgeons still use these. And I just wanted to show you. So
yeah, that's great, Alex. Thank you for that. Sorry, go ahead.
Yeah, I just wanted to announce next week's, because next week I'm really proud to host my colleagues from Norway. It's Dr. Clemens Weber and Dr. Ivar Austevoll, with their outstanding publication about the value of additional fusion surgery in degens spondylolisthesis, the New England Journal of Medicine paper from 21. This will be our guests next week, and I'm looking forward, and I'm happy to see you all again next week. So this would be next week's schedule.
Perfect. Great guests. Yeah, they've been very involved, and I love their discussion. Alex, thank you so much. You, Dr. Gibbs, of course, Dr. Baisa, and others. Daniel's on the chat. Really nice discussions. I always learn a lot from you, and I love to see that perspective. And I think you're right. Technology is changing, instrumentation is changing, but the old and true and tried principles never fall out of fashion here. So Thanks, Alex. Thanks very much, Dr. Mameghani, and we will see everybody next week. Have a good night, everyone.